Heart failure is a complex system in which essentially anything that impairs the heart's ability to function can cause it. The heart's function, as in its cardiac output, is equal to the product of heart rate multiplied by stroke volume. Left ventricular failure is backup pressure into the pulmonary system. So symptoms include dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, nocturnal cough, and pink frothy sputum. Right ventricular failure means there's backup pressure into the peripheral circulation. So you would have pitting edema, abdominal tenderness due to hepatomegaly, abdominal jugular reflux. The most common cause of right ventricular failure is due to left ventricular failure or pulmonary hypertension. So you would see a Kussmaul sign, which is when the JVP rises during inspiration. In left heart failure, all these symptoms are due to pulmonary edema, so bilateral crackles can be heard. The edema can progress into pleural effusion and also result in the vital capacity being decreased by 1/3 of its maximum. The decreased systolic pressure results in oliguria and a S2 gallop. Other symptoms include weight loss, increased heart rate of more than 120 beats per minute, and cardiomegaly. These symptoms are known as the Framingham criteria. On this criteria, minor symptoms include ankle edema, as it's most commonly seen in chronic heart failure. Abdominal tenderness can be translated into liver issues, and nocturnal cough, dyspnea on exertion, and oliguria aren't as specific. Key features indicative of congestive heart failure would be paroxysmal nocturnal dyspnea, Kussmaul sign, and S3 gallop. To diagnose, the patient needs 2 major or 1 major and 2 minor criteria. Workup: types of investigations to do. ECG should be performed on all suspected heart failure patients. It may indicate the underlying cause of the heart failure, so look for an infarct or an ischemia, hypertrophy, or arrhythmias. Echocardiogram is used to confirm the diagnosis. It can also calculate cardiac functions. Ejection fraction is important in heart failure, and less than 40% is strongly indicative of heart failure. 40 to 49% is suggestive of heart failure. It can confirm any underlying structural abnormalities such as valvular disease or dysfunction in contractility. As a natural compensatory mechanism to hypervolemia and tension in the muscle, the heart releases peptides, which have diuretic, natriuretic, and hypotensive properties. The atria releases ANP, and the ventricles release BNP. The vascular endothelium releases C-type peptide. Measurement of BNP allows for predicting prognosis and monitoring the patient. A BNP value of less than 100 means heart failure is unlikely. 100 to 250 means it's compensated heart failure. 250 to 500 is suggestive of both diastolic and systolic dysfunction. 500 to 1000 means it's decompensated heart failure, and more than 1000 means there's an increased risk of substantial heart failure. Other tests include testing for renal dysfunction, CBC for anemia, checking for electrolyte imbalance such as urea, potassium, and so on, and to rule out thyroid dysfunctions such as thyrotoxicosis or myxedema. With congestive heart failure, the increased pulmonary venous pressure can be graded into 3 stages with its own radiographic features. These provide a logical sequence of signs in heart failure, but patients don't necessarily come in with all of these symptoms. Stage 1 is vascular redistribution. In a normal chest X-ray, upper lobe vessels are less prominent as the lower ones carry more blood flow. In chronic heart failure, pulmonary venous pressure increases, causing a redistribution of blood flow. The lower lobes get constricted, making the upper lobe veins more prominent. These are also known as Antler sign. The heart failure can also cause cardiomegaly. Heart size is considered too large when the cardiothoracic ratio is more than 50% on the chest X-ray. Stage 2. The most characteristic change in stage 2 are the curly B lines. The increase in pressure causes fluid leakage from capillary beds into the interstitial space. These normally get drained through the lymphatic system, but now the system is distended. This shows up as small lines that collect peripherally on the lower bases. These curly B lines are perpendicular to the pleural space. Do not confuse this with curly A or C lines on the other areas of the lung. When fluid leaks into the peribronchial vascular interstitium, it is seen as thickening of the bronchial walls, also known as peribronchial cuffing. The decreased definition of these vessels cause a haze known as the perihilar haze. Stage 3 involves a cotton wool appearance due to alveolar edema, resulting in nodular opacities, and the opacification of surrounding alveoli make air-filled bronchi dark, resulting in a phenomenon called air bronchograms. The haze develops into a consolidation, and finally pleural effusion can also be seen with the blurring of a costophrenic angle. Heart failure is a syndrome which has a wide range of classifications. It can be classified as acute or chronic, left or right, or low or high input, systolic or diastolic. In systolic versus diastolic, systolic heart failure implies a reduced left ventricular ejection fraction, and a diastolic heart failure implies that there is a preserved left ventricular ejection. To better understand this is a normal heart with the normal pressure and size. In diastolic heart failure, there is a failure to relax the ventricles. With these stiff ventricles, the contractility needed to pump is normal but with a smaller volume of blood, as in the ejection fraction is preserved but with hypertrophic ventricles. In systolic heart failure, there is a failure to contract. Due to the lack of muscle contraction, the heart can't pump the blood strongly and efficiently, resulting in a decreased ejection fraction. So diastolic failure is in relation with impaired relaxation, and systolic failure is in relation with impaired contraction. So let's look at the treatment for heart failure with preserved ejection fraction. The most common cause for this is hypertension, which leads to peripheral resistance, causing an increase in the end diastolic pressure of the left ventricle. Because there is an increase in this pressure, blood won't fill the ventricles properly. It then ends up with the pooling of blood in the lungs of the patient, causing significant pulmonary edema. So this is where medicine gets interesting. Currently, the recommended treatment for heart failure with preserved ejection fraction is directed at symptoms and comorbid conditions. However, there is now a new class of drug called ARNI, angiotensin receptor neprilysin inhibitor. It's an angiotensin receptor blocker plus a neprilysin inhibitor. The inhibition of the enzyme neprilysin prevents the breakdown of BNP. Now this peptide will increase the blood vessel dilation and decrease the extracellular fluid through sodium excretion. ARBs block the arteriolar contraction and sodium retention effects of the renin-angiotensin system. This is a commonly used drug for hypertension. So after giving ARNI, we give an aldosterone antagonist, spironolactone. Eplerenone is considered as it doesn't have gynecomastia as a side effect. ACE inhibitors have a preventive role by treating hypertension. So now that we have looked at the treatment for heart failure with preserved ejection fraction, let's look at the treatment for heart failure with a reduced ejection fraction. The symptom profile of this patient is increased because there's a presence of pulmonary edema. The mnemonic that we follow for the treatment is known as LMNOP. L stands for Lasix, an IV loop diuretic such as furosemide. You give 40 to 100 mg. Within few minutes, ventilation reduces preload, and within 30 minutes, there's a reduction of circulating volume and preload. Morphine is given because it has a slow venodilating effect. Nitrates decrease both preload and afterload. Oxygen is given preferably with a CPAP or a BiPAP. This raises intra-alveolar pressure and reduces transudation of fluid. The position of the patient should be propped up, raising the head of the bed, or in a sitting position. This reduces venous return to the heart and decreases preload. Ensure the position first before starting with the rest of the treatment. Now, in cardiogenic shock, there's a pump failure and muscles are very damaged that they cannot contract properly. Norepinephrine is the first-line treatment. It increases coronary blood flow, allowing the heart to perform better. IV inotropic drugs such as dobutamine is used to increase contractility and cardiac output. IV dopamine helps enhance renal perfusion and prevent renal failure. If none of these medications work, intra-aortic balloon pump is considered. To follow up a patient after reducing their threat of complications, the main goal now is to reduce mortality. We give ARNI again, and then we give them ACE inhibitors, which reduces afterload and preload. Beta blockers are also given as it decreases the heart rate, reducing the O2 consumption, but only selective ones, such as metoprolol, bisoprolol, and carvedilol. Diuretics are the most effective in providing symptomatic relief to patients. The most common one being used is loop diuretics such as furosemide. Aldosterone antagonists such as spironolactone is used. Eplerenone is an alternative to spironolactone as it does not cause gynecomastia. When using ACE inhibitors, always start with a low dose to prevent hypotension. Monitor the blood pressure, potassium, BUN, and creatinine. Not all beta blockers are equal, so remember that these are the selective ones for congestive heart failure. For spironolactone usage, monitor serum potassium and renal function. This is proven more effective for advanced stages of chronic heart failure. Digoxin is recommended as it's a positive inotropic agent, but remember it's only provided for short-term effect, as it can also cause cardiovascular problems. It's used in patients with very severe congestive heart failure or severe atrial fibrillation. To remember these better, diuretics are used for symptomatic relief, beta blockers have a clear benefit and definitely should be used, and ARNI is considered the first-line treatment for heart failure.